Welcome to the University of Washington and the Office of Public Lecture special series, Coexisting with COVID-19. I'm your host, Hanson Hossein, co-director of the Communication Leadership Master's Program. Every Thursday over the last 8 weeks, we explored what our new normal might look like as we all struggled with the impact of the COVID-19 pandemic. That impact is enormous, from how we inform ourselves, how we sustain love under lockdown, what we do to shore up our public safety nets and supply chains, to what we need to do to shore up ourselves, our mental health, and our ability to make a living as change hits us so quickly. We are all learning and adapting even as we can learn from the past. COVID-19 isn't just a threat to our lives, it's a shock to our entire system. Anne-Marie Kimball from episode 7 likes to say, pandemics really find their path in the fissures of society. For us, that's our dysfunctional politics and our disenfranchised communities. In this 8th episode, we'll tackle the future head on. Special thanks to UW Marketing and Communications, the Population Health Initiative, my own Communication Leadership Program, and UW Video. Tonight, COVID-19, models and predicting the future. It's been the experts' predictive models that have catalyzed governments around the world to take action over the last few months. The University of Washington's Institute for Health Metrics and Evaluation, IHME, has been on the front lines of those fast shifts in public policy. Its data projections helped us all visualize the spread of the coronavirus and its devastating wake. IHME released its newest model this week, and it has great implications for how we might have to switch things up this fall. We'll discuss that, along with its latest research on racism and health, the major fissure in our society. As you registered for this conversation, we asked you to use the Thought Exchange platform to respond to this prompt. What would you like to ask our panelists about disease mapping? And here are the results. We'll be using Thought Exchange later for your questions to our guests. Joining us for this crucial conversation from the IHME are Chris Murray and Ali Mokdad. Ali Mokdad is the Chief Strategy Officer for Population Health at the University of Washington. He's also a Professor of Health Metrics Sciences at the IHME. Ali has done groundbreaking work on local-level disease trends and some of the leading risk factors for poor health. Prior to coming to the UW, he worked at the Centers for Disease Control and Prevention, the CDC. Chris Murray is the director of the IHME at the University of Washington. He's also chair and professor of health metrics sciences. Chris's career has focused on improving health for everyone worldwide by improving health evidence. Before he came to the UW in 2007 to create the IHME, Chris was an executive director at the World Health Organization. He also pioneered the global burden of disease approach that measures health loss over time. What would you like to ask Ali and Chris? Use the Thought Exchange platform to submit your questions. You can also vote on which questions are most important to you. It's important to hear from you, as I will integrate those questions into the conversation, so please use the QR code you see on your screen to share your thoughts. You can even snap a photo of that QR code with your smartphone, or just follow the instructions on the screen. Ali and Chris, welcome.
Thank you.
Well, Chris, this is either great timing or terrible timing, depending on your point of view. You have a new model, as we said. What do we need to know now?
Well, for the first time, we've gone global on the modeling. So we've been able to produce projections for essentially all countries in the world. And that went live today. We put out new numbers for the U.S. yesterday. And I think there's a few high-level points. First, for the U.S., we're expecting about 180,000 deaths, unfortunately, by October 1st. But we also put out for the first time some alternative scenarios, like not just what we think will happen, but what could happen if we did things differently. And one of the most important that we put out is that if we could get everybody to wear a mask like they do in Singapore, 95% of the people wearing a mask when they are in any interaction with other people, we could save 33,000 American lives by October 1st. When we look outside the U.S., what we're seeing is huge epidemics unfolding in the Southern Hemisphere in Latin America, Chile, Argentina, Brazil, Mexico, closer to home, a very large epidemic, and those will lead to hundreds of thousands of deaths in the region. And we're also seeing the epidemic take off in South Asia. And that's also going to be a huge death toll unless mandates come back in or mask use gets to a very high level.
So,
So,
go ahead,
yeah,
please.
grim news in the sense that the epidemic is now entering a worse phase at the global level.
Given that, how much does this latest model surprise you as we've been tracking this over the last few months?
It surprises us in the sense that the world put mandates on every country in the world in the same short 2-week period in March, irrespective if they had a big epidemic or a small epidemic. That really controlled transmission in low and middle income countries in a way that nobody expected it would be that successful. But because of the economic hardship, now the mandates are coming off, and we're now seeing the epidemic take off in the low and middle income world. So the surprise, I think, is that just how quickly we've gone back to, essentially the epidemic in exponential growth mode.
That's interesting. Ali, we heard Chris talk about the implications of this new model, the latest model, and also in terms of the impact. We began this pandemic in March, especially with this idea that we were all in this together. And then we've learned that isn't necessarily the case. How much has this impacted your work and your perspective on what has to happen moving forward?
So at IHME, we've been doing a lot of work on measuring health disparities and figuring out what's causing it in order to fix these problems. And Chris and I are involved in several projects. You mentioned the global burden of disease, where Chris not only measures what's killing us, but what's ailing us. So like mental health, back pain, neck pain. And we had a agreement with the National Institute for Health to do burden of disease at the county level by race, ethnicity, and socioeconomic factors. And right now what we are seeing that COVID-19 is coming on top of these health disparities. And before Chris and I have published that disparities in the United States measured by life expectancy is increasing with time rather than decreasing, unfortunately, between counties. And I'm concerned with COVID-19 coming on top of these health disparities and the economic consequences of the shutdown will impact the poor and the vulnerable and the minorities in this country. And I'm really concerned about the future health, the impact on health.
And how, given that concern, Ali, how will that impact the work that you do moving forward?
So in addition to the previous work that we were doing at IHME, right now, after what we have seen in the past and with the Black Lives Matter movement, that we have came as an organization and we said racism in this country is a public health issue. And we at IHME have the power, and we will, and we can, and we will put a number on racism. We really need to be able to show how much systemic racism is impacting public health. And we strongly fear at IHME, unless we are able to measure it, we cannot fix it. And we want to put all our resources to provide the best information on the impact of racism, not only measuring health disparities by race. That's really misleading. It's racism that's accounting for these health disparities in many occasions, and we want to do so at IHME.
So, Chris, IHME is tackling racism, as we heard from Ali. You presented for the first time this concept of alternative scenarios with masks. So you're clearly sort of wading deeply into some of the big public conversations currently around the pandemic. How surprised have you been around how politicized this public health issue has become over the last few months?
Well, I think it's to be expected. These are profound choices for societies. Initially everybody rushed in to put the mandates because of the sort of fear of the pandemic. And as the just extraordinary economic consequences, the poverty impacts have unfolded, the pressure has mounted on governments everywhere in the world to do something, to sort of do the impossible, manage the pandemic and stop the rise of poverty and the decline in income. And it's natural that in those settings, when you have people are caught between a rock and a hard place, it's going to become intensely political.
So, yeah, no, I've mentioned Wall Street Journal last week. You probably saw this, what COVID models get wrong. And we call out IHME specifically, and they're really worried that this is going to inspire lockdowns moving forward. And so when you're faced with that kind of public pressure, how do you go about continuing to do your work, given that people really want to stay open as much as possible?
It's not our role to tell governments what to do. It's our role to map out what we think is going to happen so that hospitals can plan and people can be ready to take care of patients when they need high quality care, whether they're a low income country or a high income country, and also to map out what might be strategies that are available, like getting everybody to wear a mask. It's almost free as an intervention. A mandate from every state government in the country to wear a mask can save lives and actually keep the economy going because it'll help us avoid reimposing mandates. So our job is to help decision makers sort of see what the options are and how they can balance those really difficult choices. And of course, the public is going to weigh in on that as well.
Yeah, I think that's helpful that we saw, especially here in Washington State, Governor Jay Inslee has essentially mandated, universal mask usage. And if that falls in line with your scenarios, that should ideally alleviate some of the statistics in this state at least. So thanks for sharing that. Ali, I would like to go a little deeper into this concept of racism as a public health issue. How do you actually measure racism? Because all your models are clearly based on the science and data that allows people to understand, to visualize, and to take action. What do you do with regards to racism to make that happen, especially with regards to the pandemic?
We have a long way to go. Unfortunately, in the United States, all the data that's being collected right now doesn't capture racism the way we would like in our institute in order to be able to measure it and its impact on health. But we can start by looking at the data we have right now. For example, IHME will soon release police violence by race, by county, and by state first, and then by county. So we have some data that we can show there are some racism here and some different way of how people here of color have been treated. The other thing we can do at IHME is by showing the disparities by race, ethnicity, and showing, for example, from some work that Chris and I have done before, where we have showed, for example, that African-American males' life expectancy increased the most in New York City, for example. We can show that still is falling short behind the life expectancy of white people in New York. But it's very important to show that in places when you level the playing field and you allow everybody to have access to the right things, a proxy of racism, they will flourish. And that's the things that we can do right now. If we don't have a variable at IHME to measure racism because of the lack of data, what's the proxy for it that we can use at IHME to show disparities in health outcomes, educational outcomes, and economy as well, and flag it so we are able to deal with it?
Yeah, I'm really intrigued by how you do put together these models based on data and variables. Chris, it's clear to me that what has changed a lot is you have to take into account changing human behavior as you think about your models. How much has that affected the work you do, or have you changed any of your methodology to be able to account for what is clearly an unprecedented situation, but also obviously unprecedented research for you to be able to study this?
No, we are learning as we go. We are actually now on our third generation model. We started off with a model that was strictly a statistical, it was called curve fit. It was fitting a curve that we had seen was the epidemic curve with social distancing in place, first in China, then in Italy and Spain, and then we applied it in the US. And then we realized that that wasn't good enough. It wasn't going to capture the nuance of some states opening up earlier than other states. Different patterns of interaction in different parts of the country, different levels of mask use. So then we went to a second generation model, which is a blend of a statistical approach and a transmission dynamics approach. And now we've also improved that, and we have a third generation model. So we're learning as we go. And the reason it's so important, you identified the critical issue. There's three big factors that we've got to take into account. The sort of usual ones about the virus, about sort of structural things about different communities that affect the transmission of the virus, density, how many people have to use the subway to get to work, how many people live in dense housing and can't socially distance. Then there's the behavioral part. How much do people avoid each other? How cautious are they? How do they adapt to when things start to look sunny outside and things look better? Do they forget about social distancing? And then there's the government response. And it's that dance of trying to predict all three of those to come up with what's likely to occur in the future.
And I have to ask you, it is sunny outside right now, especially here in Seattle, which may surprise some people. But what is your tangible expectation come this fall with regards to, as you see this model play out, what do you expect us to be facing then?
Well, the comparison of what's happening in Argentina and Chile to what's happening in Washington is really telling, because Chile and Argentina have still got full lockdown in place, but the epidemic is growing exponentially in those settings. Whereas we're, out, people, if you look at the cell phone mobility data, people are way more mobile. They're almost back to baseline. They're out and about. Some are wearing a mask. A lot of them aren't. So why is it that things are still under control in Washington and it's exploding in Chile and Argentina? And the answer is seasonality. That's the Southern Hemisphere. They're entering the winter period where transmission, we know, is going up. And we're in the good period where transmission is going to go down despite rising mobility right through until August. But the problem is that now that we know statistically that there's quite a seasonal pattern, it means that we are going to expect a big surge starting in September and just growing all the way through to February. And that, the big worry here is that people are getting a false sense of security, that things are sort of under control in Washington. But come the fall, kids back in school, seasonality turning on us, we think it's going to go back to a bad situation.
That's interesting. I guess we can thank the Southern Hemisphere for giving us that cautionary tale ahead of time. Ali, I just want to send a question. We received a question from our audience that I thought you might be able to speak to based on the work you've been talking about. Can you speak to how COVID impacts different populations, the poor and the vulnerable, as you mentioned? Maybe give a bit more specifics about how those particular groups are being affected differently from others.
So we know from data that we have right now that COVID mortality is much higher among African American, Hispanics, and minorities. So we know we have the data. Some states are releasing that data. And as I mentioned, IHME will publish that and show COVID mortality by race, ethnicity, very important. But what people forget when they look at this is that minorities are more likely to get the disease because of their job requirement. I can work from home. Many people have to work outside, and their job are required to sustain the economy. So in one way, we ask them to do a job to support all of us without protecting them. So they're more likely to get the disease. And once they get that disease, unfortunately, because of the history, and we know socioeconomic impact on factors impact on health, because they have more risk factors, less access to medical care, less access to quality medical care, they're more likely to die from it. So they're facing two challenges: increased exposure, they get the disease; increased mortality, unfortunately, once they get the disease. And the third part that we haven't looked at right now, and we would like to examine at IHME, and Chris can talk more about it, is the long-term impact on different groups in the United States, because many people delayed healthcare for one reason or another. Many people are going to face challenges paying their rent, buying their food because they lost jobs. And we know this will impact minorities more than the regular white people or the privileged people here in the United States.
Well, Chris, we'll probably come back to you a little later to ask you about that long-term impact upon different groups in the United States. I do have a specific question for you as well from our audience, and it's asking for advice, so you might feel comfortable. But how comfortable would you feel putting an 86-year-old on a plane from Australia to Seattle this summer or fall? This is somebody who lives in an assisted living community. Is that a life or death decision for that particular family?
Very difficult. Depends on the reason for them coming, but I wouldn't do it. I have a 98-year-old father in New Zealand, and I certainly wouldn't hope to see him on an airplane anytime soon. And it'll only be worse in the fall. So if you have to do it for other reasons, the best time will be, end of July.
So basically what you're saying is that we are not back, as much as it looks like we're back to normal, we're not even close back to normal. We have to be very careful of the risks out there still, even if we can't see them.
Well, we're not back to normal, and we think it'll start to get worse again. And unfortunately, I think we're in for a year of this, is our best assessment.
Yeah. I wanted to stay on this a bit longer with you in terms of, given that you made this last model very global, we're beginning to see the comparative differences between different countries and their political cultures. You know, what is trust, what is freedom? So you have Sweden and South Korea that have high trust societies and they've done things differently, and America, which values freedom, maybe over trust of their government. What does that imply with regards to our ability to weather this pandemic in terms of that ratio of trust to freedom? Do we need to trust more to be able to get through this, or is that not the case because we're seeing the outbreaks in Sweden in even higher, despite the fact that they trust their government there?
You know, I think there's a combination of when governments make the right choices and the population, you know, the community trusts the government. That's a potent, effective combination. I don't think Sweden personally made the right choices. I think they've been too laissez-faire and they've ended up with much higher death rates than their neighbors, than Norway and Finland. And may experience higher death rates going forward because of their strategy. You look at a place like Korea or Japan or New Zealand right now, which is, you know, spectacularly successful at controlling the epidemic, also high trust settings, and the governments have you know, adopted effective strategies. So it's that combination that's great. Another one that's really interesting is Greece, where because everybody on both sides of the political spectrum spoke with one voice about, you know, being serious about tackling the epidemic, they've been remarkably successful compared to their neighbors on controlling COVID.
That's really interesting. Ali, we've been receiving a lot of questions on the race issue and the disparities issue, and I'm just looking through them really quickly to see which one I'm trying to give you the easy ones, but they're actually all pretty interesting and challenging. Maybe this one. I'll try this one. It might be a Chris question. With the challenges of stress on health facilities in underserved areas, how much does the model weigh the lack of care and the access to basically reflect upon that? Because there are counties and pockets within cities that may be more limited in terms of their access to health care, or things are being underreported because of how they're seen. And how does that all play into the model as you think about it?
Chris can answer this better, but we're going to move into doing this by county, so this will help. But Chris may have something to else.
Okay, I'll go back to Chris then specifically in that, because the other questions really were, you know, how do you do factor racism into these models, and what is the correlation between disease mapping and racial equity? Is that have you answered that already, or can we go a little deeper on that?
No, let me answer the questions, the first that you asked me. IHME is now moving to do COVID projections by county and by race ethnicity. So that will allow us to show disparities. What the question is, in certain places, like I live in King County, I have access to a good medical center. That's not true 2-3 hours from here for people who don't have insurance or access to a good health center. So yes, we are concerned about rural area because there was a full sense of security. They haven't seen COVID-19 as it spread in big cities where it started first. And they may have relaxed and let down their guards. So now we are seeing it in some rural area, and it will be devastating. You've heard about the meat packing and etc., where COVID-19 is reaching everywhere. We're all susceptible for it, and it's going to spread everywhere. When it comes to race, ethnicity, and its impact of COVID-19, as long as we are looking at the data that we have right now, and we will publish it by race and ethnicity, we can see how much it's impacting minorities. And one of the projects that IHME is looking at, not only mortality by race ethnicity at the county level, but access mortality by race ethnicity. And that will capture if there is an increase in mortality due to delayed care or anything else among minorities. When we measure access mortality, we could see the indirect effect on mortality from COVID-19, not only the direct effect.
That's good. Thank you. Well, Chris, I'll come back to you then on this models question. Then, in terms of access to healthcare, underreported areas where people don't necessarily get to go see somebody to see whether they actually have the pandemic. And so, how do you reflect that in the model if there is this disparity in access to healthcare and access to those numbers?
Great question. We have, essentially being forced to focus on reported cases and deaths. We all know how deaths were missed in nursing homes, and eventually states got round to reporting it. In other countries, Ecuador, Peru is the best examples, because reporting has been quite poor, we've been able to take advantage of looking at weekly all-cause mortality deaths from all causes, comparing that to weeks in previous years, and getting the excess mortality, which is what Ali was starting to talk about. And there's been a little bit of that in the U.S., but it's been only released at a very aggregate level. We don't have detailed causes for it, but we've started to investigate the all-cause mortality as well to see if we can get a handle on how much under-registration of death there still may be. And so that opens up a strategy to figure out, is there actual under-registration still? The other strategy that's becoming live right now is, as antibody surveys are conducted in communities, we can compare and see if there's more infection in the community than we expected to see based on the number of deaths. And that's another powerful way for us to potentially detect if we're under-registering deaths somewhere.
That's interesting. Ali, you and Chris have both been on the front lines on these issues. I know that you're more on social media than Chris is. In your Twitter feed, you've done some really interesting advocating, especially around wearing masks. And we're hearing that masks is obviously a major variable for your model moving forward. And one question we have is, aside from masks, what else can we be doing to beat these models or improve these fatality rates, you think?
When we go outside our house, to stay as much as we can away from each other, keeping that safe distance is very important. Hygiene, washing hands is very important, but mask is the one that we see in our data that has the most impact right now. If you wear a mask, assume yourself you are infected, and then stop spreading the disease to everybody else. That's one of the cheapest, as Chris said, readily available. You can make one at home. And we have looked at data on masks. That masks are more effective than others for sure, but all masks do work, and they reduce the transmission of the virus by 1/3.
And Chris, this also gets to you guys. Both of you have done an amazing job of communicating to the public, and Ali was just talking about what he was doing. This question is: we aren't back to normal, but people are acting like we are. How can we communicate the lessons of these models beyond the beyond the less approachable graph? So obviously, when you look at the model on the IHME website, there's this graph, and it's pretty visual. But is there a better way for us to be able to communicate to the public that you got to do this to make this better?
It's a super important question, because we want to beat the projections, as you said. We don't want them to happen, and we want to persuade people, both individuals, wear a mask. Globally, we're seeing we can save hundreds of thousands of lives just in the next 3 months if people could all be persuaded to wear masks. And then on other fronts, we want to persuade decision makers, if things get really dire, to reconsider some aspects of mandates so that we can balance the economic outcomes with saving lives. It's all about communication. And so I think we want to try lots and lots of different strategies. Ali and I are on TV quite often, trying to communicate, through words. But if anybody has a great idea on how to communicate these super important messages, we are always ready to get good ideas.
Well, as you might have heard, I've been part of this master's program in communication at the university, and we actually have a lot of our students out there with an agency called, actually consulting with organizations around our region, helping them communicate better. So we're trying to do our part. I mean, it's connected to another question. People want good news right now, and these models are bad news. Are there models accounting for cognitive dissonance towards bad news? Like, we're so biased towards bad news that we might not want to take action or whatever else. So that, I think, gets back to your communication challenge around this, I imagine.
Absolutely.
Yeah. So Ali, I'm just looking to the next few years. This series has really been focusing on coexisting with COVID-19, and we've been trying to figure out what is the new normal. We've had pandemics in the past, and we seem to have forgotten them very quickly once we're through them. What do you anticipate the big systemic changes or impacts that we might see, even if it's an estimated guess at this point, a few years from now, based on this experience that we've had?
No, that's a very good question. But before, you asked Chris a tough question, that these are bad news. And, we at the IHME have built a reputation by doing the best science out there. And, I am about to retire. Chris is not allowed to retire. But anything we do, this is the only time that I look at what I'm doing and I wish I'm wrong. And I wish that people will change their behavior, government will do the right thing, and the numbers will come down. So that's very important for us, that we go out and say, this is what we see in our data, and we provide the best protective message for everybody, for decision makers. Now, for answering this question, what I would see on the long run, short of having a vaccine, we have to live with this virus. And even we have a vaccine tomorrow, we will require 8 billion doses, and we have to produce them, distribute them, and deliver them. And we may need more than one dose for some of these vaccines. And first, as you and I know, the first line of defense for us is our medical system. So we need to give them to all our medical staff in order to make sure they can provide the best medical care. So all of this, keep it in mind, we're susceptible to this virus that can easily spread among ourselves. So we have to adapt to it, and we have to be ready to make the hard decision, whether you are at the government position, which I don't envy at this time, or at the personal level position. And we have to be ready for another lockdown. And we have to prepare ourselves for it and prepare our economy for it. Unfortunately, that's what we really need to do right now in order to handle this COVID-19. The next step for us is also to build trust in our medical systems. Right now, many people are delaying basic needed medical services because they're afraid to come to a hospital. And I want to stress it today that in our hospitals here at UW, infection rate among our staff is much lower than infection rate for COVID-19 in our community. So it's safe to go out, get your screening, don't delay it, get your immunization, keep your kids up to date to vaccine, and we have to find this balance in order to rebuild our country and our economy.
Yeah. Well, Chris, I know that given how rigorous you are with your models, I won't ask you to look into any sort of crystal ball, but just listening to Ali speak about the hard decisions that have to be made and the policy decisions that have to be made, I know, you've had incredible access to governments around the world. We spoke about communication to the public. Your model used to be called the Chris Murray model by the White House. How do you communicate your latest work effectively to governments and health ministers so that we can take appropriate action over the coming months?
We use lots of strategies to reach out to governments, and governments reach out to us. We're also working very closely with the World Health Organization. They're a very effective organization at the regional level. So, this week we've had a lot of emphasis on the Pan American Health Organization, and working with them on communicating these results to ministers in the Americas. Same now happening in Europe, and we're working through other regions as well. So we have a lot of direct exchange. Part of that is listening very carefully to what are the types of concerns and ideas in each place. So every country's got a different set of challenges that are on the top of their list, and they're thinking about often innovative strategies or combinations, and they're often asking us to give quite, detailed answers as to how those strategies may play out. And it's great. It means they're engaged and we're able to communicate. It also means that, in theory, we have a ton more work to do to support, those types of decision making.
And I have to ask you this, and if it's too political for you, you can refuse to answer, but you used to be at the World Health Organization, and you were speaking about the World Health Organization in your last answer. How do we manage this with the United States basically pulling out its support of the World Health Organization? Isn't that a pivotal organization for us to be able to address this on a global basis?
WHO has an absolutely critical role for helping the world, through these difficult times and helping transmit good science and good evidence to them. And many countries in the world look to WHO for technical guidance and leadership. And so it's why, we're very keen to work closely with them in getting the sort of information that we can help provide into the hands of the people who can make better choices.
Yeah. Ali, I think a final question for you is, given that you have made this, which I think is momentous decision to essentially identify racism as a public health issue and then to rigorously study this, what do you anticipate to be the outcome once you're able to put out a model that does reflect racism? When will this happen, and what do you think the impact will be from that?
At IHME, our work is about details and getting the details right in all our work, especially GBD, because when you're measuring mortality from all diseases, if you make a mistake in one, you're going to make a mistake on the big number as well. So the details are very important for us. And in order for us to address what we see in racism, first thing to make a change, as Chris was talking about COVID-19, is by providing a projection. We're engaging people to make a decision either at the personal level or at the government level in order to mitigate that and make it not happen. Same here in racism. You cannot change what you cannot measure unless we provide a measurement for it, where it is, how it's changing, how it's impacting other things, health, economy, education. We're not going to be able to address it, and we're not going to be able to change it. We need a number, and we need to measure it like we measure how many people have COVID-19 right now. And unless we are able to do it as such, we're not going to be able to change it.
Thank you, Ali. Chris, final question for you. Your work and Ali's work has been so pivotal in helping so many of us understand this and take action. What is your fervent desire? What would you like to see happen next for us to be able to take positive steps over the next few months, over the next few years?
You know, I think what I'd like to see is that everybody sees themselves as agents of doing something about COVID. This is not just about what government does. This is one of those situations where everybody has something to contribute. Really simple, you know, wear a mask, avoid contact wherever possible, and, you know, get ready mentally, psychologically, with your family for what will be a while. It's not going to be over in September, and we all need to mentally prepare and be ready to take on this challenge and do what we all can to contribute to keeping it under control and, you know, minimizing the number of people who die.
Yeah. I think that's really important as well. Well, thank you, Chris Murray and Ali Magdad, for helping us look into our collective future and really for your essential work. And that concludes our 8th episode of Coexisting with COVID-19. You can now binge watch the entire season at bit.ly/coexistarchive. But this won't be our last. And first, a bit of context. The Graduate School's Office of Public Lectures reached out to me in late April asking me to host a 5-part series on this subject, which we would start 2 weeks later. Now, I used to be a breaking news TV journalist, but even to me that sounded like a quick turnaround and a tricky production, given the shelter-in-place order. But we found strength in the support of family and in the people that I would be working with. I served on the Office of the Public Lecture Speaker Selection Committee for nearly a decade and know its capable leader, Yvette Moy. Her colleague, Molly Mandeltort, has been pivotal to the success of public lectures in the last few years. I also have confidence in my communication leadership students that we assembled to produce this show. They're professionals that are pioneering best practices in pandemic-era live events: Richard McLean, Frost Keaton, Susan McLaren, and Roger Cadill. And with excellent technical and creative support from Trent Shepard at UW Video and designer Jesse Rancleve, we knew we could go for it. Our agile ways inspired the UW to order 3 additional episodes, and then we got renewed. Yes, Coexisting with COVID-19 will return on for Season 2 on September 10th. And for now, I'll leave you with this behind-the-scenes image of what it looks like to produce a live show of this caliber in the middle of a pandemic. It wasn't easy, it was risky, and we felt absolutely compelled to make it happen. Thank you for joining us for this season of Coexisting with COVID-19. I'm Hanson Hossein. Be good to yourselves this summer and to each other. And as you heard from Chris and Ali, wear your mask.